All right. So I was just discussing with Renee, we've got this like considerable backlog of questions that come in during the week, and every week like half a dozen questions come in, and every week I answer one question from the backlog and then talk live the rest of the time. And so every week we've just got more and more backlog questions that are yet to be answered. So not quite sure what to do with those, but we're thinking maybe a special Q&A episode one time or something. But anyway, I've got one I'm going to have a stab at. And in the meantime, if any of you people have a question, type it into the chat or just compose it in your brain and you can unmute and verbalize it. But just let me answer this first one, which is from Ivor. And Ivor says, I'm working through the Introduction to Mat Work course now, and I've noticed I have a lot of trouble sitting up on my tailbone, especially when legs are stretched out forward, which makes exercises such as spine stretch forward and saw quite uncomfortable, especially in the first position. I don't feel like I can sit up tall and my lower back rounds. Could this potentially be due to very tight hamstrings, hips, glutes, and something that will improve through more practice and working on flexibility in those areas? Any other suggestions are very welcome. I also weightlift and wonder whether that may be counterproductive to flexibility or just a myth. Would love to improve this area before I get started in Feb. Well, I'm sorry I'm way too late to help you for that, but because now we're in almost the end of April, and but I think I can help you with an answer to that. So I feel like doing a little anatomy drawing, so you guys, all of you, well, I know many of you on this call, you're Pilates instructors, so, most, if not all of you, must have an opinion on this. Why can't Ivor sit up straight when she's in the start position of spine stretch forward with her legs straight out in front of her? Hey, Kylie. Who's game enough to unmute and share the answer? Andrea, I can tell you know what to say. Come on, just unmute.
I'm just laughing that no one is jumping in. I don't know, but I'm thinking, is it something to do with tight hamstrings?
Yeah,
probably.
Yeah, hamstring stiffness. Does anyone happen to know roughly kind of sort of what the average range of motion, because in that position, right, you're sitting, I've moved my desk around, every device has swapped sides. I feel like I've travelled from Australia to the US and now I'm driving on the wrong side of the road. Every time I go to press a button, it's not where I think it's going to be. Anyway, I wanted to press that button. So when you're sitting up, ready to do spine stretch forward, your hips are in flexion, right? So that's hip flexion. So does anyone happen to know or want to take a stab at what the average range of hip flexion with a straight knee is? Like if we got, I don't know, just say we got, 1,000 people and we, lay them all down on their back like so, and then we had an assist, they're laying on a table maybe, and then we had an assistant push their leg, pushing it that way. Like, can you kind of sort of decode that picture? Maybe if I did it in different colours, it'd be a bit easier. But there's, here's the person who's being measured. Do you know what that angle would be there? That angle of the hip? How many degrees, roughly, kind of, sort of? Anyone want to take a stab at it? I know a couple of you have done the course with me and I know we talked about it. How's your memory? Take a stab at it. Go on. Type it into the chat or unmute. Kylie said 120 degrees. Hey, Kylie, can you show us the leg trick? Yeah, Kylie thinks 120 degrees. Kylie thinks everyone can do the splits without warming up because she can. Vicky said 90 degrees. Andrew said 90. According to Kendall et al., it's 80. So 90 is pretty close. But it's not the same as 90. 80 is not the same as 90. So if we looked at that there, if you lay down on your back and you lifted your leg up, 80 degrees would be about there, right? Not quite vertical. And so then if we transpose that person to sitting up, let's see if my skills are up to this. Not quite, apparently. That one. Bam. All right. So there is our 80 degrees. And now if we take the other leg and put that other leg with it there, okay, there's 80 degrees. So that's the average, and this is according to Kendall. They measured, probably Caucasian college students in the 1950s, right? So in North America. So that's the average range of hip flexion for those people. But let's just say for the sake of argument that that's about normal now as well. So 80 degrees, well, you can't sit up straight if you've got 80 degrees of hip flexion. And moreover, when Kendall et al., measured that, when they do that test, they're doing passive hip flexion. So they're, you just lie there and someone lifts your leg up for you and they see basically how high they can lift it before you scream. And for most folk, that's an average, if you're not Kylie, of 80 degrees. So, not quite vertical. And that's called passive range of motion. So in other words, someone else is, you're not lifting your own leg into that position. Whereas when you lift your own leg into that position, that's called active range of motion. And what we find is that active range of motion in everyone is less than passive range of motion. So let's do a quick test. If you stand and stick one leg up on a chair or a table or something, you can probably, I can get to about 80 degrees. You can probably see there that my leg's not quite horizontal. My torso's, kind of vertical-ish. So, I'm feeling a pretty good old stretch right now. Okay. And so, if you do that experiment, you'll feel that you can get to, you get to some particular angle, right? And then just stand there, take your leg off the table or the seat and lift your leg up and see how high you can get. And you'll see with me, I can't get my foot up onto the table, right? I don't have the same degree of active flexibility as I have passive flexibility. And that's probably going to be the same for all of you, even for Kylie. So for Kylie, it would be probably dropping into a full split passively, no problem. But if she's standing, she probably couldn't lift her leg up unaided into a full split just by the strength of her leg muscles, right? So active flexibility for everybody is generally less than passive flexibility. And so does this make sense? Does this kind of make sense, what we're saying so far? All right, and so when you're sitting up in that position, right, is that active or passive? What do you reckon? Type it in or unmute. Yeah, Beck's put in 80 to 140 as well. I reckon you're probably more towards the 140, Beck.
Is it? Can you hear me, Ralph?
Yeah.
Active, because then you've got, your own body weight that's kind of holding you down. Right.
So you basically, if in this position, right, if you relaxed all your muscles, what would happen? Would you stay in that position? No, you'd find yourself, you bonk your head on the floor as you lay back down, right? So gravity wants you to lie flat, and so to be in that position, you've got to use your muscles, right? So that's an active position. So instead of raising the leg, though, you're just raising the torso, but it's the same thing, right? So the muscles that are working to raise your torso in this case are the hip flexors. right? So if you're lying on your back lifting your legs, it's the hip flexors. If you're sitting on your legs lifting your torso, it's the hip flexors. It's the same muscles. And so they're lifting and they're lifting the weight of your torso, and they've also got to overcome the resistance, that's meant to be a spring, of the stiffness of your hamstring muscles, right? So it's the weight of your torso plus the resistance of the hamstring muscles against the strength of the hip flexors in this case, right? And that's, so if you've got 80, all right, so if you've got 80 degrees of, if you're an average person, right, not a dancer or someone at the more mobile end of the spectrum, if you're an average person, you've got about 80 degrees of passive hip flexion, right? You're probably going to have a bit less than 80 degrees of active hip flexion. You might have 70 degrees of active hip flexion, right? Well, 70 degrees is going to look even less vertical than that. Let's see if we can get rid of all of that scribble. And if we wanted to then get, touch or sit up as straight as possible, right? So that's as vertical as we can get our hips. But just say we wanted to get as vertical as possible, well, you then have to round your lower back, don't you? To get it. And, that's the position that Ivor was talking about. And that's what what they're seeing there is, roughly kind of sort of 80 degrees. Whereas in reality, for most people, it's going to be a bit less than that. They're going to be a bit tighter than that. So the answer there is why can't you sit up on your tailbone? Because you've got average flexibility in your hips. That's why. And the second part of the question is, can you train it? And the answer to that is, yeah, absolutely. If you just do that more, you'll get better at doing it. So, yeah, that's why you can't sit on your tailbone. But I think the only kind of what I would say is, I wouldn't say it's because of tight hamstrings. It's just because you've got normal hip mobility, right? That's actually normal. That's not tight. That's how humans are designed from the factory in most cases. So, to get 140 degrees of hip flexion doesn't happen by accident to most people. You have to work for it. So I wouldn't describe that as tight. I would just say, if someone's in class and they're struggling to do that, as like if you have a room of 10 or 20 people and you're doing spine stretch forward, guaranteed, unless it's a room of dancers or acrobats, half of them are going to struggle to get into the start position comfortably. So rather than saying if you're tight, in your hips and you can't get into this position, say something like, if you find this uncomfortable, or if you're struggling to get into a straight position here, you can bend your knees, or you can sit your bump up on a block or whatever. But rather than saying it's tight, just say if you're struggling here or if it's uncomfortable, here's what you can do. All right. Tess has sent me a great question. And Tess, you sent me this in the, and good to have you with us, by the way. You sent me this question in the week as well, and I've been ducking it. So, all right, so you've got me now. Tess says, "Hi, Raph. I'd like to hear you discuss muscle cramping in the legs and feet. I have male clients who always get cramps in their feet and hammies. They can't lie prone or 4-point kneeling without having to put their toes in extension. What is or are the causes? I've heard various explanations. Is it more common in men? What can be done to prevent it? Thank you." Well, you're not going to thank me, because all I'm going to say to that is I don't know the answer. I'm sorry. So I have looked a bit into cramping, and I don't think it's very well understood. And the something I have learned is that the thing about magnesium is not necessarily true. Like, have more magnesium, that'll stop you cramping. So, but yeah, basically it's a big don't know, and I'm going to have to look seriously into that during the week, I promise. And I'll make a little special video for you, or you know what, I'll answer that first next time. So yeah, sorry about that one. All right. And Tess sends another question as well. And this is awesome, because actually this is great, Tess, because these are some of the backlog I've had during the week. I was just reading your question that's actually had like 10 questions in it and thinking, oh crap, that's like 10 weeks of work. So this is good. We can knock it all over. I loved your cueing podcast. Can I ask you a question in relation to this? In terms of cueing, we are cueing to make the client's movement better, is my understanding. I.e., if a client is supine, doing double leg lowers, and they're getting lumbar extension, why wouldn't you cue to encourage lower back towards mat so they can maximise the hip range of movement without unwanted, for this exercise, lumbar extension? Or if you're doing cervical thoracic extension, baby cobra, in prone, albeit it's a max range of motion of 10 to 20 degrees in the thoracic, and they move immediately from the lumbar thoracic joint, so common, would you cue to get the movement initiated in the upper spine? Thank you. Tess, we agree, you and I, on that. So if we were lying on our back doing leg lowers, the straight double leg stretch essentially, and somebody was really arching their low back, they're not going to be getting the most out of the exercise because a lot of that exercise is about working your lower abs. And if you let your lower back arch, well, you're not getting you're not getting that focus or that benefit from that particular exercise. So I would cue to bring their lower back to the mat, but I would use an external cue rather than an internal cue. So it's not about whether you cue body position, it's about how you cue body position. So in this case, if we were lying on our back, I would simply say, everyone put your hand under your back, feel the arch of your back where your back's kind of off the mat a bit. Okay, feel the back of your T-shirt there, press the back of your T-shirt down into your hand and squash your hand into the mat. And so you don't have to use the hand, you could put a rolled up sock or a bit of a flex, scrunched up flex band under their back and say, squash the flex band. So I'll just use an external cue rather than an internal cue. And if you did use an internal cue, like push your lower back into the mat, it's not the end of the world, they'll be fine. But it's not, I don't really think it's any more difficult to say something like push the back of your waistband into the mat or scrunch up a flex band and put it under there and then squish that or something like that. I don't think that's particularly, more clunky than saying push your low back into the mat. So, just an external cue. And the same with like the mini cobra you're talking about. So if you're lying on your tummy and you got your elbows on the mat and you're pushing up and you want to extend the cervical and thoracic, okay, so somebody's kind of hinging, you're saying at their sort of thoracolumbar junction, where the thoracic spine and the lumbar spine join. Well, if you want to get maximum cervical range of motion, you'll be looking at the ceiling because, the average person's got something like 90 degrees of extension in their neck, right? And by the time you do that, if you just sit, relatively upright now and look up at the ceiling, did your thoracic spine move? Yeah, it moved, right? It's pretty hard to look straight up without also, without doing some kind of thoracic extension there as well. So I reckon I would just cue look at the ceiling or, look as high up the wall as you can, that kind of thing. If you wanted, and I don't see a problem with the thoracolumbar joint extending if they're extending the upper back and the cervical spine and that's what you want to have happen. If they also extend the thoracolumbar joint, well, what does that matter? That's fine. If they're extending everything. So that would be my approach. If you really wanted to, and I can't really think of a particular reason why you'd want to, but if you really wanted to prevent them from moving at lower down the thoracic spine and, isolate the movement as much as possible, again, I would use like an external object, like, their bra strap, like don't move your bra strap or, put an external object on them, like get them to hold a flex band in each hand. Okay. And the flex band goes around their back and cue them to slide the flex band up until it's over the bit that you want to bend. it's over their mid-thoracic or something, and then say, okay, curl around the flex band. So don't push into the flex band, go around the flex band. So yeah, I would experiment with those types of cues. And if you're physically in person with them, you just, let them know you're going to, and then put your finger on their back, or, put a toning ball or something on their back there for them. Yeah. So those are my thoughts on that. And Tess says, excellent. I've been using external cues since your cueing podcast. Well, looks like I'm telling you stuff you already know then, Tess. So my apologies for that. Another question from Tess. This is awesome, Tess, because you've sent me so many questions during the week. I can't remember if this one was one of them, but I think it was actually. Yes, it was. All right. And in fact, it's about pelvic floor, and I've actually been researching the pelvic floor this week because I had a chat with Chloe, and I had a chat with Anthony Lowe, a friend of ours who's a pelvic floor physio, last week for the podcast, which will be coming out in a couple of weeks. And also I'm writing an article for Men's Health on the men's pelvic floor. So I've been thinking about this a bit. All right, so I'd love to hear your views on the pelvic floor muscles and the core. You've mentioned that it's not essential to be cueing this with clients given the sophistication of the autonomic motor system. I have clients that feel like they're bearing down on their pelvic floor and can't keep their abdominal engaged when doing exercises, typically exercises with increased intra-abdominal pressure, e.g. series of 5 prone work like swimming. It's not often, but always the female clients who have had babies, not necessarily in the past couple of years. So if we're not internally cueing, what would be your recommendation? Ooh, this is a great question. All right, so when there's two parts to it. One is doing supine exercises, so abdominal exercises, like series of 5, your crisscross and your single leg stretch and your straight single leg stretch and all that. And then the other one is prone exercises like swimming, where you're in extension and you're lifting up using your back muscles. So, and people can't keep their abdominals engaged when doing those exercises. So what would I cue? All right, well, I'm going to throw it out to crowdsource. What do you guys reckon? You can type it into the chat. You can
try and encourage.
You go ahead.
Try and encourage breathing through it, so you're not breath holding.
Awesome. Who's that? Sorry.
Sorry, Raph. That's Beck.
Hey, Beck.
I'm eating. That's why I've got my camera off.
What are you eating?
It's some kind of wrap.
Oh, nice. Oh, yeah.
It's got hummus and things like that.
Oh, it's a homemade one.
Yeah, it's a homemade one.
So you know exactly what kind of wrap it is.
But yeah, I don't usually cue breath for exercises, but if someone is visibly, breath holding, and I breath hold in certain exercises are pretty challenging for me as well. And then, to just remind yourself or remind the client, breathe through it.
Mm-hmm. I'm not sure if that's quite the question. The question is pelvic floor muscles and core. You've mentioned that it's not essential to be cueing this with clients given the sophistication of the autonomic motor system. So basically what I've said, what I'm on record as saying is that if you don't cue the abs, they'll work just fine by themselves, and the pelvic floor and whatever.
Yeah.
And if your pelvic floor is not working, you know it because you wear your pants, right? And so if you're not wearing your pants while you're working out, your pelvic floor is working just fine. So we don't need to cue it. And so Tessa's question is, okay, get that, but what about clients that feel like when they're working, they basically bear down on their pelvic floor? Like you're doing a bowel motion on the toilet, right? There's a kind of a bearing down feeling and can't keep their abdominals engaged. So what in that situation, what would I cue? That's the question. Is that the one that you thought that you were answered?
No, sort of. Sorry, I kind of was thinking about to help them stop bearing down and break that that sort of stuff. But I don't know, maybe less range of motion, try and just bring it back a little bit and see if you can bring it to a point that they feel like they can control the movement a little bit more.
Anyone else got a view? Want to throw your 10 cents worth in? Carly said, would you necessarily need to cue the abs when in a prone position? Because if you're in extension, you're stretching the abs. That makes sense to me. So I would say in swimming, you probably don't want your abs on. You probably want your back muscles on more. So I would say that's not a problem in swimming or other extension work. What about in that series of 5? All right. But let's do an experiment. I know it's not an experiment because I know the result, right? But let's try it together. So put your if you've got some kind of a wrap or something, put it aside for a moment, and let's do the series of 5 with me. We're going to do it with your hand on your abs. It was a short series of 5, but my sense is you're not all doing it with me. Come on, lie down on the floor and do this with me. We're not going to do the whole series of 5, I promise you. Right? So lie down on the floor, curl up your torso. You can choose whichever series of 5 you want to do. You can do the single leg stretch, the double leg stretch, the straight single leg stretch, the straight double leg stretch, the crisscross. You can do them all in that order or just choose your favourite one. Okay. Now curl up into the position, right? Because they're all in a curled up position, right? With your head and your upper back off the mat and basically the base of your shoulder blades just touching the mat. Okay. And then your lower back's pressed towards the floor and your legs are off the floor. Right. Now in this position, okay, put your hand on your tummy. Okay. And you'll feel that your abs are on. Right. Now you might go, oh no, I'm feeling jiggles or wiggles. Like, yeah, but underneath whatever's on top of it, right, your abs are on. Guarantee. Give yourself a good hard poke, like in the tummy. You'll feel abs under there. I promise you. Right. Now in this position, relax your abs. What happens? Now, if you totally relax your abs, you should notice that you're lying flat on the floor with all of your body parts on the floor, right? Let's try this experiment again. Lie on the floor with your knees bent, feet on the floor. So they call it crook lying, right? So you're lying on your back with your knees bent, feet on the floor. Put your hand on your tummy. Take a deep belly breath. Really relax your abs. Just let your tummy go soft, okay? Buddha belly, okay? Now, keep your hand on your tummy. Keep your abs really, really, really relaxed. Okay, this is a test, and a test of how well are you able to keep your abs relaxed. Okay, so keep your abs relaxed. Now, keeping your abs relaxed, lift one foot off the floor. Keep them relaxed. Don't tense your abs. Whatever you do, use all of your mental powers. Don't tense your abs. Okay, did you manage to do that? Did you notice that your other foot's pushing into the floor a lot now? All right. Now, keeping your abs really, really relaxed, take your other foot also off the floor. So now both feet are off the floor. You tensed your abs, didn't you? You tensed your abs. Okay. Put your feet down. Relax your abs again. Keep your abs relaxed. Now, keep your abs relaxed. Lift your head and chest off the floor. Keep your abs relaxed, though. Lift your head and chest off the floor. Can you do it? Keep your abs relaxed. Go on. You guys are body aware. Can't you just like move one part and keep another part relaxed? All right. Did you enjoy that experiment? You can hop up now if you want, or you can keep doing the rest of the session lying down. Why not? So why did every single one of you fail to relax your abs during that experiment? Why is that the case?
Because the abs are the muscles required to do those movements.
Precisely. Right. So when you're lifting your head up or your chest up or your legs up, your abdominals are required You know, like there's no way you can do it. Like if you had some kind of paralysis, spinal cord injury that you couldn't activate your abs, you wouldn't be able to do those movements. Right? The abdominals, particularly the rectus abdominis, but also the internal and external obliques, are the prime movers in that chest lift movement, and they're the main stabilizers in the leg lift movement. So if someone's doing the series of 5, right? So what's wrong with this? What's wrong with this statement? During series of 5, my client can't activate her abs. What's wrong with that statement?
It's not a true
I
statement.
believe that she's not activating her abs.
Right. So the client very likely perceives that she can't activate her abs. Like she's going, oh, I'm not feeling my abs, right? So just, you guys have done series of 5, right? In a proper class, not like mucking around like we just did it, right? So you do your single leg stretch, then you do your double leg stretch, then you do your scissors, your straight single leg stretch, then you do your leg lowers, okay? Then you get to the crisscross, right? Have you ever got to the end of that and gone, oh, I can't feel my abs? You know, like, do you ever get to the end of that series and go, what's this one meant to be working? Right? But just imagine this client, right, is so freaking strong that she gets to the end of that series and she goes like, oh no, I just can't feel it anywhere. I mean, don't you hate those people that are so strong like that? So I would say that's a high five moment, gold star moment for that client, that if they can't feel their abs in that exercise, they're definitely working, and there's no need to cue. As for the kind of feeling of bearing down, that is a when you pressurize the abdomen, like when you do a curl, you know, like any kind of flexion movement, you do increase intra-abdominal pressure, you know, the pressure inside your abdomen, and that does increase pressure on the pelvic floor. So, you know, there is increased pressure on the pelvic floor, and if someone has incontinence problems, that can cause incontinence, right? So if the client was incontinent, if they were basically leaking urine in that exercise, that is a good signal that something needs to change, and they need to relearn how to do that movement in a way without bearing down. But that's not our job. That's a pelvic floor physio's job, because they need to probably do an internal exam to check whether those, you know, to check the function of the pelvic floor, because often with stress incontinence, which is what that's called, it's the pelvic floor is not necessarily underactive. In a lot of people, it's overactive. So us just cueing more or less pelvic floor is not necessarily going to help that situation without us actually knowing what's going on in the pelvic floor, and we obviously can't check that. So that's why if there's a urinary incontinence issue, or if there's pelvic pain associated with that, you know, genital pain associated with that movement, then I would suspect, oh yeah, some specialist pelvic floor cueing might be a good thing here, and that person should go to a specialist female health physio that can do a sort of a gloves on, you know, exam and give the woman specific cues for her particular pattern of muscle activation, rather than a generic, hey, do more pelvic floor or do less pelvic floor type cue. But that doesn't sound like the problem that you're describing. It's just someone saying, oh, hey, I can't feel my abs in this exercise. Well, that's awesome. You're awesome. So strong you can't even feel your abs.
Raph, can I ask a question there as well? What's, like what you said, unless someone is actually incontinent, why is there the idea that bearing down is bad? Do you know what I mean? Like if I'm doing the hundreds and I'm, you know, happening to not be drawing in and up or whatever, you know, why is there that perception that that's bad?
Honestly, I don't know. It's a really good question. And
it's not something I teach or anything like that. I just, you know, just a lot of things that, you know, you hear and see and that sort of stuff. And I just, while you were talking about it, just thought, why not ask?
Yeah. Yeah. Anyone else have any ideas on that? Actually, we talked about this with Anthony. Chloe and I talked about this with Anthony in relation to doming is another one. You know, like when people have a abdominal separation in postnatal, when you're doing Pilates in postnatal, you know, when you have an abdominal separation, sometimes when you increase the pressure inside your abdomen, so basically when you do a plank or an ab curl or some other move that requires you to tense your torso, the pressure inside can push out on that sort of more elastic linear elbow, you know, like the mid part of your abdominals there, and it can kind of, you know, bulge out a little bit, and that's called doming. And there's, you know, I mean, if you've ever heard of that doming, you've probably heard of it in the context of it's not a good thing and we should avoid it. But Anthony asked the same question, like, well, why is it not a good thing? And I'm not going to give you a spoiler because he's got I had a brain exploding emoji moment when we were talking about it. And he, because of something that he said about this, that made me think like, oh yeah, why is that? Why is that necessarily a bad thing? So yeah, I think with the pelvic floor thing, it doesn't necessarily make sense to me that it's necessarily a bad thing either to bear down, you know, unless you're incontinent, right? So if you've got a uterine prolapse or urinary incontinence or some other, you know, pelvic pain issue that occurs when you bear down, well then, yeah, it makes sense to reevaluate how you're doing that. But if you're happy as Larry, you know, I don't see why it's a problem. Yeah, that's a really great question. In fact, that's something I'd never questioned until just the moment you said it. So well done, Beck. Brain exploding emoji moment. Yeah. So all right. So Tess, I'm not sure if that answers your question satisfactorily or not. I'm very open to you being dissatisfied with that answer. Any thoughts? I'm guessing Tess is hiding under the desk at work and can't say anything. We have people doing that. So, all right. So there's one final question also from Tess. So thanks, Tess, for keeping the conversation going today. This is awesome. If you have time, I'd love to hear your view. I have a client who many years ago was diagnosed with a posterior lateral disc protrusion between L1 and L2. So posterior means backwards, lateral means to the side. Disc protrusion is super quick lesson on disc terminology. You've got your top view of a disc. That's the front. They're kind of lumbar ones anyway, are kind of kidney shaped, and they've got these kind of concentric rings of ligament basically wrapped around. That's what the disc is made of. And in the middle, there's this kind of, it's like a Kinder Surprise egg. It's got kind of a, you know, liquid core in it. And the outer part here is called the annulus fibrosus, which means the round and fibrous, you know, tough. So it's basically the tough, round, you know, annulus, like in a year, an annual goes around, you know. And then the inside part is called the nucleus pulposus. And that just means the middle bit, and that means soft. Or I think that means like the kernel or something like that, the soft inner part basically. So there's the tough outer bit and the soft inner bit. And when you are human, often you have some version of a disc bulge. And we know that these occur commonly in pain-free people, but more commonly in people with pain. And so there are a few different versions of a bulge. And so the two basic ones that I want to talk about just for a moment here are an extrusion. Okay, extrusion. Extrusion. Whoops. I actually got that back to front. That's actually a protrusion. Protrusion. And that one there is an extrusion. And that is the only difference between those is this one is wider than it is deep. You know, it's wide and shallow, and this one is sort of narrow there. Okay, so it's deeper than it is wide at the base. So it just describes the shape, protrusion, and it just means it's relatively broad and shallow compared to an extrusion. So a protrusion, a posterior lateral protrusion, posterior means the back, lateral means the side. So this in fact is a posterior lateral protrusion. And then goes on to say between L1 and L2 pressing on his sciatic nerve. In class, he reports left side pain when doing increased repetitions and increased range of lumbar extension. He gets nervous when he feels discomfort and wants to avoid building up strength in full range. I'd be interested to hear more about the research on this and also your approach to guiding and encouraging clients like this. Any thoughts? This is one of those ones where there are two things not right about this statement. See if you can pick up what they are, just from an anatomical, biomechanical standpoint. I'll read it again. I have a client who many years ago was diagnosed with a posterior lateral disc protrusion between L1 and L2, pressing on his sciatic nerve. In class, he reports left side pain when doing increased repetitions and increased range lumbar extension. Two things wrong. Can you pick any of them? Do you want to have a crack at it? Do you want me to read it again? Many years ago, was diagnosed with a posterior lateral disc protrusion between L1 to L2, pressing on his sciatic nerve. In class, he reports left side pain when doing increased repetitions and increased range lumbar extension. Any guesses? All right. No guesses, eh?
I just put in the chat that it was many years ago, so it's not accounting for healing in that time.
That's a third one. So discs pretty commonly heal, and they generally do so within about a year. Not all of them do, but they commonly do. So that's another one for sure. All right, I've got more chat. Okay. So here's your lumbar spine. L5 is the lowest, L4, L3, L2, L1. So the left posterior lateral would be the left L1, L2, okay? So it would be the disc in between L1 and L2, that disc there, okay? And that would be the sciatic, posterior lateral, would be there, okay, where the nerve root comes out, okay? And the nerve root is just that kind of bulbous bit there, okay? So that is L1, L2, posterior lateral. All right, pressing on the sciatic nerve. All right, well, here's the thing. The sciatic nerve goes down the back of your leg to your foot, okay? And it exits your spine at L3-4, L4-5, and L5-S1, okay? Down at the base here, the bottom 3 levels of your lumbar spine, not at L1, L2, right? So if you've got a disc bulge at L1, L2, it's not pressing on the sciatic nerve because the sciatic nerve isn't at L1, L2, it's at L3, 4, 5, S1. Does that make sense? Yeah. All right, so that's one thing, right? Second thing is just say the client got it wrong. Maybe it was at L3, 4, right? Maybe they got it wrong, right? And it is pressing on the sciatic nerve. If you press on a nerve, right, so just imagine that here's this sciatic nerve, okay, it comes out here, okay, L3, 4, and that nerve, just imagine it goes down here, goes down through this greater sciatic notch here, okay, and then goes down, down your leg, down the side of your leg, all the way down your calf to your foot, all the way to your little toe, right? So if I squeeze your little toe, okay, how you know I did that is that sensation is transmitted up the sciatic nerve, okay, to your brain, right? And if you want to wiggle your little toe or, move your calf muscle or you bend your knee or, use any of the muscles in your leg, in the back of your leg, essentially, the way you make that happen is you send a message down your sciatic nerve to those muscles to tell them to turn on, right? So your sciatic nerve is pretty important in terms of the function and sensation in your leg. So if I came, imagine I was an evil scientist, right? And I did some kind of operation on you and then basically like crimped your sciatic nerve. Just put maybe a pair of forceps or something, some kind of thing that not cut it, but like just clamped it. Clamp, that's what I want to do. I'm going to clamp your sciatic nerve, right? What symptoms do you think you might experience? Apart from terror at being in the clutches of an evil, mad scientist, what symptoms do you think you would experience if your sciatic nerve was clamped? Well, the sciatic nerve feeds sensation basically from your foot all the way up your calf and in your hamstrings and stuff up to your brain, right? So if someone poked you in a little toe with a pin, the only way you'd know that, unless you were watching, would be by the message being brought up by your sciatic nerve. So you'd experience a loss of sensation in a leg. From Carly, that's correct. You might experience pain in those parts of your leg, like down the side and back of your leg, down the back of your calf and into your little toe. Okay, you might experience pain. There's all other sensations. So it might be like, if someone tickled you with a feather or you dropped hot coffee on your leg or something, like you would know about that because the sciatic nerve would transmit those sensations as well. And so we have different nerve endings for heat, that sense chemical, that sense pressure, that sense vibration, that sense all these kinds of different things. So you might get, feelings of buzzing or heat or wetness on your leg. That would just be the sciatic nerve, just imagine like the electrical signals all getting mixed up in where it's clamped, okay? And you might feel that. And also you might, as Vicky said, feel weakness or have weakness because if your brain sends a message to your hamstrings to contract, but the message can't get through where the nerve's clamped, right? So the brain's going, hey, contract, but nothing's happening, right? And then you would walk funny, right? Because you couldn't contract your hamstrings properly or your calf properly or lift up your foot when you walk, so you'd kind of drag your foot around, okay? So you would have like potential, have anything from, pain, tingling, numbness, loss of sensation, altered sensation, weird things like you could swear to God that someone's pouring warm honey down your calf or, like just people would get weird sensations in their leg, pain or loss of motor function, so loss of the ability to contract those muscles. Essentially you'd be partly paralyzed in those particular muscles. All right. What were the symptoms that were described in this question? Do you remember? What were the symptoms? I'll read it again. I have a client who many years ago, prior to the healing time being elapsed, was diagnosed with posterior lateral disc protrusion between L1 and L2 pressing on his sciatic nerve. In class, he reports left side pain when doing increased repetitions and increased range of lumbar extension. That suggests left side back pain to me. Doesn't say anything about pouring hot honey on your calf muscle or, can't move my little toe or anything like that. Does that make sense to you guys? So, right, so number one, L1 and L2 is not where the sciatic nerve is. Okay, and the client could easily have got that mixed up, right? The physio tells them one thing and then they tell the instructor something different. It happens all the time. And the second thing is, even if it was pressing on the sciatic nerve, you would expect to get leg symptoms, weakness, pain, numbness, loss of sensation, whatever it might be in the leg, not back symptoms, because the sciatic nerve doesn't innervate the back, it innervates the leg. Right, it's a different set of nerves that innervate the back. So, anyone else get pain when you do a back bend ever? Yeah, come on. You're telling me like you do your swan dives and you never feel a lick of discomfort? It's all just like nirvana. Yeah, I think a lot of people experience discomfort in those positions, and I'd say that's just probably pretty normal. Tess, if you really, really wanted to, get to the bottom of this anatomically, what I would recommend is you ask if you can. So my sort of take on this is it's probably nothing to write home about. It's almost certainly not involving the sciatic nerve because there's no leg symptoms and it's in the wrong place. And it sounds to me very, very much like just garden variety back discomfort when doing extension, which like 8 out of 10 people have, okay, and there's nothing to worry about, just, keep on about your business. But if you wanted to really get the bottom of it, because it does sound like the client's possibly got the message mixed up somewhere in between receiving it and then transmitting it onto you, is I would ask the client if you could see the scan report, the report by the radiologist that says which spinal levels are involved and where the disc bulge is and all of that kind of stuff. And then, and if you wanted to, you could then work with the client. I don't know if this is an in-person client or someone you're seeing on the internet. It'll be a little bit easier in person, but you can still do it on the internet, is compare the location of the symptoms to the location of the findings. Okay? So by which I mean, first you have to read the radiographer's report, right? The scan report. How did they know there's a disc protrusion? Well, they must have had an MRI or a CT scan, right? That's how you find these things. So I ask, can I read the MRI report? And the MRI report will say, just say it says posterior lateral disc bulge L1, L2, right? Just so the client got it right. Well, here's L1, okay, because here's the T12. That's the lowest one with the rib on it, okay? So there's L1, okay, there's L2. So there's L1, L2, okay? And you can find that on yourself. Find your bottom rib, ribs are fairly easy to find, okay? You can feel it with your fingers. You also can feel it on the inside. Like when you press on it, your brain goes, yeah, I don't like you pressing on that. That's not a comfortable place to press, right? Because the ribs are protecting your kidneys. So they're going, yeah, no, don't press there. Right, so that's your bottom rib. That's your T12, okay? Your 12th thoracic vertebra. Like 1 inch below that, in the middle of your spine, that's your L1 spinous process. That bony bump there, okay, that you can feel in your kind of upper lower back, okay, that's your L1 spinous process. Go down about 1 inch, there's your L2 spinous process, okay. Can you kind of find something that you think might be your L1 and something you think might be your L2? Right, well, in between those, halfway in between, that's where your L1, L2 disc is, right? And this test says here that the client says it's on the left L1, L2, right? So it's just a bit off center, halfway between the L1 and the L2 spinous process, right? So that is where the finding is, right? And so then I would say, all right, so that's where your finding is. So can you show me where your pain is? Right? And so do a couple of cobras or whatever, and the client will go, oh yeah, my pain's here. And then just go, okay, well, is that the same place that we just said your finding is, And if it's in the same place and the client's like L1, L2, yeah, that's exactly where my pain is, then I would be tempted to think, maybe that disc is still a bit irritated, or maybe it's, there is something in there, it's a bit inflamed or not, not happy with the world. But which seems to be equally, if not more likely, the client points to an area like 2 or 3 or 4 or 5 or 6 inches away from that and says, no, my pain's here, then I would be scratching my head and going, well, how could a disc bulge at L1, L2 cause pain, 3 inches away and more lateral or something? So I would just be thinking like, oh yeah, that there's a pain in your back and there's a disc protrusion there from 10 years ago, but those two things are probably unrelated. They're probably just coincidental. And the disc bulge, like Vicky suggested, is probably well and truly healed by now. Yeah. So does that process make sense of comparing the location of the findings to the location of the symptoms? Do you reckon you could have a crack at doing that with a client or with a loved one or with yourself? I think that's that's something we teach in the diploma these days, is when you read the scan report, because so many people have no pain and then get a scan report for whatever reason. They have degeneration or arthritis or a disc bulge or whatever. It's very common to have those things and not have pain. So then someone does have pain, they get a report and scan done, and then they find, disc bulge or degeneration, but they might have had that for 20 years and not had pain from it and then got pain from some other reason. So it's really important when you have someone who's got a finding like that and also has pain, to think about, okay, well, what are the factors that would make me more suspicious that the finding and the pain are related? Okay, and what are the factors that would make me less suspicious about that and make me suspect maybe actually the finding's unrelated, it's just incidental. It's just a red herring, as they say. Yeah, so I hope that helped, Tess, and I hope and thanks also, Tess, for those awesome questions, and thanks everybody who contributed. And even those of you who looking for the word bashfully kept your cameras off. I'm really grateful that you're here, and I trust that you're finding some kind of value and inspiration in this, and I'm really happy about that. So please keep shooting me through your questions, or even better, bring them to the live session next week. And I hope you have an awesome week. Thanks so much.